we're going to be talking about upgrading our approach to digital health design. I will ask that we hold off questions until the end, just to make sure I can fit everything in and provide a complete picture before we start discussing any topics of interest. So to begin with, I'll briefly introduce myself and share a bit about the pathway that led to interest and investigation into digital health design for older adults and those with cognitive impairments. And I always think it's important to give a little bit of background on my training, because I'm not a computer scientist, nor do I have a proper degree in human factors. So I want to make sure that you're oriented to the type of training that informs my current work. My graduate degrees were completed at The Ohio State University and include a master's in occupational therapy, and I continue to maintain licensure to practice in Ohio, and I'm maintaining my Pennsylvania license as well. And then my PhD is in health and rehabilitation sciences. That PhD was under the advisorship of a biomedical engineer, and that tie is what brought me into the technology world. It gave me the opportunity to work on various technology evaluation and development projects, and allowed me to branch off into a more personal interest in smart technology. So that's the tech side, but my populations of interest mainly center on cognitively impaired and neurodegenerative populations. So I have an emphasis on Alzheimer's disease, and I'll give you a little bit of background on that as well. My family, like so many others, has been directly impacted by Alzheimer's disease and related dementias, or ADRD. Both watching the impact of ADRD over time and engaging with my loved one who lives with ADRD as one of her many informal caregivers really solidified my dedication to investigating neurodegenerative diseases and interventions that would support health and wellness despite disease progression. The well-being of individuals living with neurodegenerative diseases is often inseparably intertwined with the wellness and capability of their informal caregivers. So these caregivers too become a priority when investigating or designing intervention approaches. Using my clinical background in occupational therapy really influences my approach to technology. Using my OT lens means that I maintain an underlying person-centered approach in really all of my work, or at least that is my goal. Because it's not about fitting people to the most ideal solution, which can certainly be a temptation when working in smart technology design, but instead it's about realizing that in order for any solution to be really ideal, it has to fit the individual person. So to close out the slide, I'll note that my training continued at University of Laval in the Cirrus Research Center, where I completed my postdoc. And immediately following that, I came here to University of Pittsburgh, where I have been here since September. So that's a little bit about me. In the way of disclosures, I will let you know that I do maintain an LLC, Show Me the Science. That YouTube channel is just a graphic to support that. I don't make money off of YouTube, but those are my disclosures for now. So here's the outline of what we'll be talking through today. We'll define mHealth and software as medical devices, or SAMDs. We'll talk about persuasive system design. We'll talk about design considerations, kind of talking specifically about dementia populations, but with the idea that the concepts we discuss can be generalized out. And then finally, I'll build off these concepts to discuss one of my projects that looks at formal technology evaluation approaches as they relate to smart tech for older adults and those affected by ADRD, or Alzheimer's disease and related dementias. So beginning with definitions, mHealth is becoming more familiar, so this might not be a completely novel concept to many of you, but for the sake of common terminology, when I talk about mHealth, I'm thinking about smart device apps that mediate or provide health and wellness supports for users through a variety of functions. Pictured here is what appears to be a glucose monitoring app, and that could be valuable to someone working to manage a chronic condition, specifically managing diabetes. And then here's what seems to be an app for tracking biometrics such as heart rate, and that could be of personal interest if you're an athlete, or of medical importance. pending the individual and any underlying chronic conditions that they live with. There are plenty of other apps that support health and function that fall outside of what we picture as, quote, medical interventions and align more with health maintenance and perhaps disease prevention approaches. It's a huge and growing list. Some that come to mind include nutrition tracking apps, medication reminders, symptom and mood tracking apps, screening apps for different conditions, sleep support, and meditation apps, among many others. So let's look at some of the definitions offered by familiar or credible sources. The World Health Organization defines mHealth as, quote, medical and public health practice supported by mobile devices, such as mobile phones, patient monitoring devices, personal digital assistants, and other wireless devices. It's essentially mobile device mediated care and health support. So by this description, numerous commercial apps that weren't necessarily designed for health can be used in an mHealth capacity. They can be used to support wellness and health span. But this is a bit of an outdated definition. You can see they reference PDAs here. So let's look at a more recent one. Davis et al. 2016 cited the U.S. Department of Health and Human Services defining mHealth as, quote, the use of wireless technologies such as mobile phones, personal digital assistants, and netbooks for improving health. Now, this definition is all the more broad and almost seems a step back from the sense that a clinician or any sort of formal healthcare needs to be tied in. Recall the last definition mentioned medical and public health practices, while this one simply says, quote, for improving health. And that's going to be important as we think about our research, our innovation, clinical practice. We have to consider which mHealth products are considered medical devices versus mHealth that would be more of an off-the-shelf product that doesn't require any higher scrutiny or oversight. After all, when we think about apps that can be used for improving health, what percentage are really tied to formal healthcare? And in my experience, that's the vast minority. But minority of what, you might be thinking? So let's look at the impact of mHealth, or kind of the numbers that are out there. The numbers are pretty incredible. As of 2015, over 28,000 health apps were available via the App Store alone. So that's tied with iOS systems, the Apple App Store. That doesn't even count the Google Play Store. And what is maybe more impressive than that is within just a few short years, that number grew to almost 54,000 by 2021. So if you're interested in integrating or maybe further integrating mHealth into your research, I'd say the trends are pretty motivating. But again, we need to really understand exactly what we're getting into. So let's talk more about the provision of mHealth to consumers. And that brings me to the idea of direct to consumer. I talked a lot about this idea in a recent lecture, and the discussion really reinforced to me that this is something we need to continue discussing. Specifically, the fact that much of the mHealth market is direct to consumer. What does that mean? Well, another example of a direct to consumer wellness support might be something like reading glasses. You don't have to wait for a doctor's prescription or an insurance company's approval. You just go buy them if you think you need them. The same goes for mHealth. You don't need much mediation to purchase a lot of the mHealth that's out there. You as a consumer really have direct access. You just go download it. In a comment piece for The Lancet, Cohen et al. 2020 wrote that, quote, unlike many other medical products and services, digital health technologies are often sold directly to and used by individual patient consumers. These technological offerings can address unmet healthcare needs by circumventing traditional intermediaries, such as payers, e.g. insurance companies and governments, clinicians, employers, and the pharmaceutical industry, and provide patients with direct access to health-related data and services. So then one of the big pros of mHealth is that they're direct to consumer. We don't face many of the barriers in attaining them. And that can make this a really widespread or more equitable form of healthcare, or at least health support. So that's one of the pros. Let me introduce you to one of the cons of accessing mHealth. And that's simply the same thing. It's direct to consumer. So while direct-to-consumer formats can overcome common barriers to access, there's also a con in the bigger picture of mHealth. There's two sides to this coin. Cohen et al. 2020 also writes that, quote, the ability of the clinician to have a valuable role in guiding the patient is hampered by the continuous and rapid entry of direct-to-consumer digital products into the market, the pace of which outstrips that of traditional medical drugs and devices. Furthermore, the absence of a common language to describe facts about digital health leaves consumers and their clinicians confused. Patients arrive at clinics with product-derived data and request interpretation of such data. So if you're a clinician, this is something that you might have experienced. Perhaps a patient or a client has come in and showed you data gathered through an app, data on a certain health marker you are interested in, you've talked with them about. And more information is great. Data over time collected that way, that can be awesome. But that's really if the scenario fits within a perfect world, if everything's done right. But what else could happen? Well, you as the clinician might have doubts or concerns about the validity of the data capturing methods, or maybe your interpretation of the data in the app doesn't align with what the app is reporting, but your client has already bought into the app. They're already confident in that. And so it seems mismatched that you wouldn't agree. Misunderstanding of data or data gathering methods, interpretation, whether on the patient or the clinician side, that can be difficult, and it can potentially really hinder the rapport, an important rapport between the client and the clinician. So if the mHealth is not regulated, the clinician has no influence in deciding which mHealth option is best, right? So then the app that your client chose to use may or may not be supporting their health and wellness appropriately. It might not be up to appropriate standards in the way that it functions. In this sense, that direct-to-consumer model can be a hindrance. The client is the expert on themselves. That's important. But the clinician brings important expertise on the medical side, and that expertise can be important in deciding whether or not a certain mHealth option is appropriate. So in sum, health supporting apps or mHealth are often direct to consumer, and this is a pro because it means in most cases, healthcare consumers have unregulated access. They avoid common barriers to equitable care, and they're empowered to attain and implement technology-based supports that could augment their wellness. And it's also a con because, again, that means in most cases, healthcare consumers have unregulated access, which can also mean fewer safeguards and absence of important clinical guidance. This is one of those areas where development and innovation have simply outpaced regulation and outpaced implementation of evidence-based practice strategies. And that brings us to our next topic, which is, where is regulation now? So the question is, should or is mHealth being regulated? And to talk about that, let's talk about software as medical devices, because medical devices are what require regulation. So software as medical devices, or SaMDs, are defined by the International Medical Device Regulators Forum as, quote, software intended to be used for one or more medical purpose that performs these purposes without being part of a hardware medical device. So the short answer is some mHealth would fall into the category of SaMD and would therefore require higher oversight or regulation. A point of clarification, software as a medical device is software that can be used or paired with a hardware, but is not necessarily dedicated or exclusive to that hardware. That would be software in a medical device, or SIMD. We're talking about software as a medical device. So we do have some definitions here, but I wouldn't necessarily say that that makes mHealth categorization and regulation clear. Let me give you a few examples of SaMDs that are provided by the FDA to kind of exemplify this ambiguity or kind of gray area. Here's one example: software functions that use a sensor attached to the mobile platform or tools within the mobile platform itself, such as an accelerometer, to measure the degree of tremor caused by a certain degree, a tremor transducer. So let's say you have an app that looks at the accelerometer in your smartwatch and gives you feedback on whether or not there are changes in the amount of tremor you're experiencing over time, or perhaps it provides information that a physician can use to diagnose tremor-related conditions. That could be a SAMD. This one is interesting to me. Software functions that present donor history questions to a potential blood donor and record and or transmit the responses to those questions for a blood collection facility to use in determining blood donor eligibility prior to collection of blood or blood components. So what are we talking about here? We're literally talking about a survey on your phone. So a survey, because of its intention and how the intention is related to healthcare, could be considered a SAMD and could require higher regulation. But plenty of surveys that we use on our phone that could even be related to health and wellness also would not be SAMDs. Software functions that use a sensor attached to the mobile platform or tools within the mobile platform itself to measure physiological parameters. They cite limb movement, electrical activity of the brain, like EEG, during sleep, and are intended to be used in the diagnosis of specific diseases or conditions such as sleep apnea. I put this one on here because I was recently at a clinical conference where I attended a tech lab. And the feature technology was an off-the-shelf electroencephalogram headband. You just put it on and you could pair that with an app. And this app worked with the EEG or electroencephalogram to evaluate the quality of your meditation as you moved through various prescribed meditation or guided meditations. And the speaker noted that you could use other guided meditation apps if you wanted to avoid the cost of some of the meditation programs within the app they were featuring. So as presented, the technology was discussed in the context of its clinical value. That's what we were talking about in this tech lab, something clinicians could potentially use with clients. So naturally, I peppered the speaker with questions on the regulation of the devices, both the hardware and the software, whether independent or in concert. And the feedback, in short, was that these were not regulated devices because they were not being marketed as clinical. The speakers, who were not the developers, were researching and positing the clinical value of these devices used in concert, but the developers had not created them, or at least were careful not to market them as clinical, meaning they didn't claim that the EEG and meditation app could be used as an intervention for clinically diagnosed disorders such as anxiety or other mental health conditions. But clearly it could be used for this. So while it was not a SAMD, understanding the clinical value with a specific FDA example in mind, a minor change to the way that this app and EEG pair were marketed could drastically change the regulatory process. It's certainly a gray area, all the more so for clinicians trying to decide what is best to use in our practice. So this is a SAMD risk categorization chart from the FDA, and this is important when considering the need for formal review or regulation. The FDA presently has a pre-certification for SAMDs and SAMD development organization that they're testing, with plans of moving forward into further beta testing, I assume, pending the effectiveness of the pre-cert program. I won't take time to play the overview video that the FDA provides simply for the sake of time, but I do highly encourage you to watch it. And I have the URL for that in the references section of this presentation, and I can also drop it in the chat at the end. But for the time being, I want to go through the clinical evaluation chart briefly to provide a better picture of the thing that in essence determines if a SAMD is of higher or lower risk, and this can then impact the review and regulation considerations in the future. So if you go across the x-axis of this chart, you see treat or diagnose. That's going to be affiliated with higher risk. To treat or diagnose is really talking about a more immediate or acute intervention. The SAMD, in some cases in mHealth, would be used to treat or intervene in a condition or diagnose a condition in the immediate or short term. Whereas if you move over to the right, drive clinical management, that's really talking about supporting a clinician as they practice or aiding them in something. It's not as much of a direct, immediate intervention. And then all the way to the right, informing clinical management, that's talking more about educating or providing information that can then be utilized. If you go to the y-axis, you see from top to bottom that state of healthcare situation with the highest level of risk would be critical all the way down to non-serious. So top left is the highest risk category, and that's going to be affiliated with higher oversight and regulation. And then the bottom right is really education CMDs for non-serious conditions. That's going to require little to no oversight depending on subjective interpretation, I suppose. In order to gain a better understanding of what a CMD is, let's talk about what a CMD isn't. The FDA's general wellness policy for low-risk devices describes software items that are considered low risk. It categorizes them under two descriptors or definitions, the first of which would not be considered to describe a medical device. This first definition describes software as having, quote, an intended use that relates to maintaining or encouraging a general state of health or healthy activity. So that's not really a medical device. The second definition, also a low-risk device, could be a medical device, and that is, quote, software that's intended to use, software with an intended use that relates to the role of healthy lifestyle with helping to reduce the risk or impact of certain chronic diseases or conditions, and where it is well understood and accepted that healthy lifestyle choices may play an important role in the health outcome for the disease or condition. And this is important. Here we're mentioning diseases and conditions. So that's an important point of clarity between the two, and what seems to be driving mHealth or CMDs that fall under this category, driving their being affiliated with medical devices. So Sarah Girk, in her recent article, Health AI for Good Rather Than Evil, the Need for a New Regulatory Framework for AI-Based Medical Devices, notes examples of software functions that fall under the general wellness category to include things like sleep and relaxation, physical activity support, weight management, and she even mentions mental acuity. These are just examples. There are plenty of other functions that apps might offer that can be used to support health, work in a preventative capacity, or be used to manage a chronic condition. But is it a medical device? That's a bit more subjective, right? So let's break down a couple more specific examples. If I were to use an app that tracks my physical activity so that I can monitor the extent to which I'm maintaining a healthy lifestyle, not a CMD. If I were to use an app that provides guided meditations that I can engage with, should I feel stress about, say, upcoming grant deadlines? Also not a CMD, but there is a bit of gray area here. What if I have an app that performs similar low-risk functions, but is intended or marketed as a method of preventing or coping with a chronic disease? Well, that's a different thing altogether. For example, the same article provides an example in which software is used to aid in making good nutrition choices that might support wellness for someone living with diabetes. This would be considered a CMD. Well, you might be thinking a physical activity monitoring app, like I just described a moment ago, that could also be used to support wellness for someone living with type 2 diabetes, and you would be correct. The crux of the issue seems to be contingent upon the intention of the app, what it was designed and or is marketed to do or to be used for. So there is a great deal of subjectivity, call for critical or perhaps clinical reasoning when deciding which apps fall into various regulatory categories. And all the more so when we as healthcare professionals are interacting with apps that don't fit into regulated categories, right? That calls for a lot of clinical and critical judgment. I think the better understanding of the criteria and stratification considerations that regulatory agencies are concerned with is and will continue to be highly important to developers, clinicians, researchers, and healthcare consumers as we continue to interact with and work with mHealth. I do want to avoid going any further into this regulatory rabbit hole, and so I will instead move forward to a few considerations that might be more immediately useful to you when subjectively assessing mHealth, whether in your research or practice. So with that, let's go ahead and talk about the idea of persuasive system design. One approach to looking at the applicability of mHealth for those of various diagnostic populations, again, in my case, that's individuals with ADRD and their caregivers, is through the lens of persuasive system design. This approach, quote, focuses on reinforcing, changing, or shaping attitudes and behaviors by addressing 4 groups of principles: primary task support, dialogue support, system credibility support, and social support. So we're in essence trying to persuade the end user toward a behavior. There was a great video, and again, I can share that through the chat. It's linked at the end of this presentation. It provides examples of persuasive system design, or PSD, that we're working to change users toward more green behaviors in the sense of more eco-friendly behaviors. So it showed various apps that would in one way or another lead the user to carry out variety of actions that would be considered more sensitive to environmental concerns without the user necessarily being conscious of it. Maybe they didn't consciously decide that they wanted to be more green, but that was the goal of the app. So it was leading them to carry out activities that would fall under that green behavior category. Things like encouraging alternative transportation options that would by default lead to fewer emissions. Now, green behavior, I think, is a good thing. I try to be eco-friendly in my own practice. However, if you're thinking that this example sounds a bit subliminal or maybe deceptive, I felt that way too. The idea of a software design trying to elicit a certain behavior out of me through various functions, especially if I'm not aware that that's the behavior they're working to elicit, that gave me pause. So PSD could be used inappropriately. Especially within healthcare, I want to be really careful to say that I encourage transparency in the use of persuasive system design. So most mHealth, I assume, to be designed with the intention of persuading the user to more healthy behaviors. And that's exactly what you want to communicate to the user. If there are other goals within the design, those two should be made explicit, in my opinion. I don't have any interest in instigating a pattern of behavior within users that they aren't interested in implementing. So with that disclaimer, let's go ahead and talk about the 4 components of persuasive system design. The first being primary task support, and that's how the app functions to aid you in achieving the desired goal. In many cases, that's going to be a behavior. This might be through providing venues for self-monitoring. It might be by providing education or guidance, whether general or tailored. Matthew et al. 2016 notes that in general, a cycle of data capture and feedback is a powerful tool in effectively persuading the user to modify their behavior. So for example, I don't know if any of you have ever used MyFitnessPal, but the MyFitnessPal app allows you to log your food and see your caloric and nutrition intake throughout the day as it compares to your overall daily goal. And let me tell you, the process of actually logging every calorie you consume and then seeing the discrepancy between what you've eaten and your daily allowance, seeing that discrepancy dwindle away pretty quickly, that truly can impact your behavior. It certainly impacts mine. So that's the primary task support within that app. Then there's dialogue support. And I used a quote by Matthews et al. 2016 because I simply could not paraphrase this description clearer. They describe dialogue support as the design principles that support human-computer interactions in a way that users would consider to be social or interpersonal interactions. It's how you dialogue with the software. So think about an affirmation or congratulations when completing a learning module in an app, or maybe beating a level in a game. There's some pop-up on the app that tells you you've done a good job, or some indication that you can celebrate now. maybe a word of encouragement to motivate you to keep trying along the way towards a goal. It's sort of the way an app interacts with you to persuade you towards a certain behavior to continue moving forward. So most of us like affirmation. We often need a bit of encouragement. So this is can be a really positive thing. I've used this example before. How many of you, and this is rhetorical, have changed to a less efficient path between A and B, or maybe even just walked around in a circle after getting a watch notification telling you how close you are to your step goal? It's such a small thing, just a little pop-up to tell you you're close to where you should be. But that dialogue between you and the software is often enough to make us change our behavior. And what's more, you may have found yourself interacting more with your watch and taking more steps in the subsequent days after attaining that goal, after that little prompt. Dialogue support. Okay, the third category is system credibility, and this has to do with trustworthiness. So affirming to users that an app or software system is backed or affiliated with a familiar, reputable organization or institution can be a way of doing this. If it's an informational app, perhaps adding to the credibility of the system by providing evidence that the content is sourced by a leader or authority on the topic that the app is providing education about. I was trying to think of an example for this, and one of the things that came to mind was making online purchases. So have you ever been shopping online, maybe on your phone, and you find something you like, you decide to buy it, you put it in your cart and click forward, only to be sent to a third-party payment system that you didn't recognize? There's PayPal, for instance, but many of us have seen that. We've used that. We're confident in it. But if you're sent somewhere else to another payment system that you don't recognize, that could be a problem. I'm not sure how you would respond to this situation, but I tend to abort altogether. I click out, shop somewhere else, or just stop shopping for a bit because I simply wasn't confident in the credibility of the system I was interacting with. How much more important might credibility be with our personal health data? There can also be within this category social proof, in which representatives from the target end user population are featured, kind of cueing or reinforcing the idea that the app is intended for the end user audience you're targeting. So if an app is designed for a specific user population, diagnostic group, maybe age demographic, then you might want the app's graphics to reflect that. So this is the last category. This focuses on leveraging social support to motivate use or acceptance of an app. And this isn't going to be relevant to every mHealth example out there, but certainly for some in which you would dialogue or connect with peers or others in a form of social support. I won't belabor this one, and here's why. There was a recent study done by Faieta et al. In 2019, and they evaluated the influence of PSD on acceptance across 4 countries of varying cultures, on app acceptance across 4 countries of varying cultures. The countries were Malaysia, the Netherlands, Saudi Arabia, and Germany. And they assessed the influence of the 4 PSD categories. And they found that PSD was indeed influential in user acceptance, but really it was primary task support and dialogue support. These were the 2 PSD components that seemed to carry the bulk of influence. This then indicates that these are the categories to really focus on in design. One of the ideas that they discussed in this article was the idea that tying or aligning software to a specific culture, maybe a small group within your target population, in order to support user acceptance within that culture might be a bit antiquated and perhaps inefficient as compared to prioritizing persuasive system design principles within your design. They say with the diminishing influence of cultural factors within the realm of apps, the design of apps can aspire to be universal. The research does not reject the influence of local cultures. However, it argues that the role of local culture should not be regarded as decisive in user acceptance. Instead, local cultures can be used along with persuasive design to increase acceptance while avoiding expensive engineering and maintenance costs. So persuasive system design being really effective. Also of note, for those of you who are interested in persuasive system design, I do encourage you to look further into that Matthew et al. Article I cited in the earlier slides, and then it's also in my references, because the 4 concepts that I've presented here are really the overarching categories. This is a high-level overview of persuasive system design. There are actually 28 principles divided into those 4 categories. So if you're designing software and you're interested in making sure that you're designing with persuasive system design in mind, make sure to take some time and get into the weeds a bit with that. All right, moving right along, I'll briefly touch on a few design considerations that I feel are important, and then I'll close out by sharing a bit about my current work efforts in mHealth evaluation. So when thinking about designing smart technology, maybe for Alzheimer's disease and related dementias, as I do, or a different population, there's not one correct set of criteria to follow or one pathway, simply because each individual, in my case, each older adult with a neurodegenerative disease, or perhaps each middle-aged or older adult caregiver, they're all unique in some way or another, maybe in many ways. So please note that if you ever decide to design mHealth or any level of assistive technology, especially for older adults impacted by dementia or other neurodegenerative diseases, what we talk about today is really a starting point. It doesn't replace the need for UX UI investigations among your more specific target end users. I'm going to go ahead and give a high-level overview of a few different design considerations. And in doing this, I'm going to be speaking to you as though you were the designer. So first, accessibility needs, thinking about things like contrast, font size, volume, method of interface with the app on a smart personal device. You want to ensure that you're accounting for users across the visual acuity spectrum. And if your target end user, as is the case in a lot of my work, is an older adult, you're going to want to think about age-related decline in vision, changes in dexterity, perhaps hearing as well. So it's not just the presentation of the app, it's also how the individual interacts with it, going back to that PSD principle of dialogue support, right? A study by Boyd et al. 2017 looked at the effectiveness of different kinds of technology-based prompts to include text, picture, audio, and video prompting. They were attempting to prompt participants, if participants had dementia, they were attempting to prompt them in completing a series of steps that together comprised a multi-step activity. In this case, they found that audio prompting reinforced by text, the presentation of text, was a really strong method. And one of the rationales that they posited was that the more concrete nature of this type of prompting as compared to pictures or videos was really good for the population of interest. So I think that the take-home point is a need for guidance that is concrete, clear, and timely, prompting the user to act in a way and at the point at which they should act. So this is an example in which researchers looked at a specific end user group and decided what sort of interface or dialogue they needed to design based on the user group's needs. This example does not necessarily generalize out to other groups. I recently read another article by Lucero et al., I think 2020, and they talked about preferable interfaces for dementia caregivers, and they didn't necessarily align with this. Again, it's finding the design considerations that are appropriate for the user group you'll be working with. But with this example, they found a way to interact with the user that accommodated their specific needs. So they wanted to present them with instructions in a way that was really clear. With a picture, there's some level of interpretation, but with words, it can be a little bit more concrete. To the point of timeliness, in this same study, the researchers looked at ways that the user might progress through the series of prompts. And what they did was design a button that appeared when the user needed to move to the next step. So they reacted to the prompt, and then they had to progress through the software, the tablet, to the next prompt, right? And so the researchers designed a next button, but the next button was delayed. It didn't appear when you got to the next screen. And the reason it was delayed or appeared a few seconds later was because they wanted the end users to be able to interact with the main prompt first and not be distracted by that next button. So this design appreciated some of the characteristics or some of the cognitive challenges that individuals within their target end user group might experience. Something else that the researchers noted, they said it's also clear that the level of prompting required for a given task will vary between individuals and for an individual over time, possibly even on a day-to-day basis as the dementia progresses. This might necessitate variable levels of prompting for the same person performing the same task. And I say this because if you're ever designing for someone with dementia or a dementia caregiver, it's important to acknowledge that needs can fluctuate not just between people, but also within the person due to a progressive disease. So just building in flexibility or customizability can be important in mHealth design for dementia or cognitively impaired population. In essence, know that even well thought out and thoughtful design and smart technology can be expected to have varying levels of effectiveness. Users, family members, they might really benefit from some education on realistic expectations. This way they can appreciate the benefits gleaned on a good day with that mHealth without becoming discouraged on bad days. So giving people realistic expectations about the effectiveness of mHealth based on the condition that you're working with. I do want to throw in just one more consideration, and that is complexity. In any design, there has to be a balance between sufficient content, functionality, guidance, and then simplicity. When I think about designing for those with dementia, personally, I'm weighing the importance of simplicity just a little bit higher. But at what point does simplicity detract from clarity? Well, let's think about the example of the next button in this study that they performed, where they put a next button so that the individual interacting with the software could progress to the next prompt. Should that button say next? Or should it say touch for next step or press for next step? Should it be enclosed in a square like a button? Or should it maybe be in an arrow? Which of these options is the most clear and which is the most simple? Because it's not always going to be the same thing. Sometimes you have to weigh out what's more important, being really clear and really concrete, or being really simple. The authors wrote, this feature highlighted the common design compromise required when designing for people with dementia, the tension between adding extra words for clarity, like touch here for next steps, and the need for brevity, for example, just next step. So this really calls us to be careful, to be sensitive to the unique needs of individuals as defined by who they are, what their support looks like, where their personal context is, and what are the needs that they face today, and will these change tomorrow? Technology effectiveness, at least in the case of those with Alzheimer's disease and related dementias, it's really dynamic. So incorporating persuasive system design considerations, especially being thoughtful about effective primary task support and dialogue support between the app and the user. And then considering accessibility and complexity in the design. These will work in concert when designing effective mHealth, or I think that they should. For example, incorporating effective prompting methods in the app so that the app can effectively dialogue with the user based on the individual user needs. Not all of us will be designing mHealth for dementia populations or otherwise. It's more likely that the majority of us will be more involved in app or mHealth evaluation, whether informally or in a clinical or research capacity. While understanding design concepts is important, formal evaluation can still be called for in many cases. Xu and Wu 2021 point out that there is currently no neuropsychological assessment aimed at determining which technology or social media would be best suited for individuals with specific dementias. Rather, decision to adopt and implement technologies into everyday life is an individualized decision based on personal needs and goals. So creation of a formal standardized assessment to guide recommendations toward particular technology or social media is an area of future consideration or future direction is what they were saying there. And that brings us to our final component of today's lecture. And that is evaluation, where I will share a little bit about the health app review tool. So this is a project that actually grew out of my PhD dissertation, and then I carried it forward into my postdoc, and I'm working to initiate it now here at University of Pittsburgh. So I'll give a little bit of background, and then I'll talk about where we are. Just to be sure that everyone's kind of has the same base level understanding of Alzheimer's disease, since this was my target population. Alzheimer's disease is a neurodegenerative condition characterized in two ways, both clinically and pathologically. 3 diagnostic criteria are used to characterize the pathological presentation of Alzheimer's disease: amyloid beta plaques, neurofibrillary tangles, and neuritic plaques. Staging was established by Thal et al. 2022, Break and Break in 1991, and Fillenbaum et al. In 2008, respectively. Essentially, what these criteria are looking at is the deposition of Alzheimer's disease pathology along a predictable pattern throughout the brain. Additionally, Marinescu et al. 2016 describes the sequence of atrophy throughout the brain as the condition progresses, and this begins in the hippocampal and association regions and then progresses throughout the brain. This is a picture of both intracellular tau and extracellular amyloid beta and collections of amyloid beta into neuritic plaques. And this is really hallmark AD pathology that you see here. So that's the pathological presentation. And then there's a clinical presentation. With Alzheimer's disease, we see a wide variety of symptoms, and this can vary by person. It can even vary by time of day. The clinical presentation can include changes in ADLs, in IADLs, such as driving, ability to work. It can change behaviors or ability to engage socially. It can have ramifications in sleep and sleep patterns, physical activity, medication management, all of which together often necessitate the support of an informal caregiver. That's often going to be a spouse or adult child. So when I'm thinking about using technology to support individuals with Alzheimer's disease and related dementia, it was important not just to look at mHealth that would support the needs of those with AD-RD, but also to look at the needs of the caregiver, making sure they were able to carry out their caregiving tasks, their own self-care, connecting with care providers, or in some cases, managing care at a distance. The well-being of the individual with Alzheimer's disease and their caregiver, again, are often intertwined. So we wanted to look at mHealth that could support either component or both components of that AD-RD dyad, is what we called it, the individual with AD-RD and their informal caregiver. So the Health App Review Tool is a unique assessment instrument that we designed to investigate two things: the person who is in need of an app and then the app itself. I say investigate because we're not really measuring either variable in the sense that one can be measured as good or bad. Instead, we're looking at different characteristics of both variables so that we can compare one to the other and find the best match between the two. I had made a quick video that shows an overview of the Health App Review Tool, so I'll use that to walk you through some of this. We're missing some informed decision-making when it comes to apps. We want to find the right app for the individual user, not say whether one app is good or bad, but to say this app is good or bad for this one user. So we created the Health App Review Tool. It's a 2-component assessment. It has both an app and a user component. And then each of these components have 4 domains, and questions on each domain are graded against the comparable question on the other assessment, so we can determine how well the app and the user fit together. So here's the heart structure. To recap, the heart is a two-component web-based assessment. Let me rephrase because this is often a point of confusion. The heart is not an app in and of itself, but rather it's an app assessment. It looks at both the user and at the app and measures each across a series of items fitting into 4 domains: usefulness, complexity, accessibility, and external use factors. And the responses to these items in the comparable domains between the app assessment and user assessment are designed to be compared using a SAS-based algorithm. It's just SAS code that we use to compare the two and determine how efficient the match is, so that we can determine if an app is good for maybe a dementia caregiver, or perhaps it's a new adopter of technology looking to support their own health. It can be somebody who's a technology resistor, but who has family to support them. Or in many cases, this is kind of a classic picture. It's an individual with ADRD and their caregiver working together to age well in the community. Here are a number of publications. I just wanted to provide these. These speak to the work I've done in the area of dementia, healthy aging, and then also development of the health app review tool. We have the initial version of the health app review tool that was 106 items, way too long. During my postdoc, we did a lot of usability testing, and we did some in-depth interviews with target end users. And through that, we were able to refine the structure and the content of the heart. It is now 17 items. They're multi-items. At present, there's an ongoing usability study being carried out through University of Laval, that's where I did my postdoc, and Fédération de Québec Alzheimer's Society, and that's primarily based on the French-Canadian version of the heart. I've just put revisions into the IRB here at Pitt, hoping to move forward with the usability evaluation of the English version of the heart. Also included in my IRB is a psychometric analysis. I want to be able to investigate the interpretation of the heart scoring, whether or not we're using the right number of strata, or perhaps it's a little bit different. We'll be able to discover that through Roche analysis. We also want to look at floor and ceiling effects, those who are really satisfied or happy with technology versus those who really aren't. Can the heart tease out or measure both groups? All right. Today we've talked about M-Health and the state of regulation versus development. We've talked on persuasive system design and M-Health development. We touched ever so briefly on design considerations. And then I provided a really quick, ran out of time, overview update on my work with the health app review tool. So with that, I'll go ahead and take questions and share my references. All right, thank you.
Well, wait a second. Hi, Pete Hill. I have a quick question. You mentioned 2 stakeholders, essentially the if you will, the patient and the caregiver. Other stakeholders factored in, which you mentioned earlier, particularly the clinicians. Are your thoughts along maybe including them in this match?
I apologize if I missed the beginning of your question or interrupted you. Apparently, I had my computer on mute. I think I got the bulk of the question. So actually, that was the original intention. When we first designed the heart, it was designed for clinicians to complete and then recommend apps for individuals with dementia and their caregivers that the clinician works with. But what we found as we did those in-depth think aloud interviews was that a lot of people were really quick to say clinicians are not going to do this. Clinicians don't have time to look at apps, much less do a formal assessment. And even though we took the questionnaire down to 17 questions, it should take about 10 minutes tops to do if you know the client and the app. Still, we wanted to make sure we were introducing an assessment that was ready for the real world. That meant if the clinician doesn't have time, the clinician doesn't have time. Right. So what we did was we worked a lot on the language so that now it continues to be appropriate for clinicians, whether or not they're familiar with technology, but a dementia caregiver could use the heart themselves. So we now consider a dementia caregiver to be one of the people who could fill out the heart to determine whether or not an app is good for them. And the idea is that the heart is kind of filling that gap for health that would fall under the radar of formal regulation. It's not a medical device necessarily, but we also don't want people adopting and trying out technologies that aren't good for them, right? Or that would just add to their burden. So this is supposed to make that process more efficient still. Does that answer your question?
Perfectly, thank you.
Julie, is there a commercialization plan for the heart?
So yes, kind of. So I created it at OSU, so it's protected by OSU. And what we did was it's under one of their like general copyright type things. And when I went to University of Laval, OSU said they could either release it to me or keep it protected there and give us access to use it. We did the latter just because we knew the postdoc was temporary. And then we've been working with, we just got that same letter from OSU saying we could continue research here at University of Pittsburgh. But the initial protections for the heart were with the intention that we could move it as needed kind of so that I could continue on the project. So I don't have a strong plan as far as next steps. I've been more focused on the research of it and making sure I developed a good assessment, but we have kind of the groundwork to at least protect it.
I see, thanks.
Other questions? I know I rushed through these. Sorry.
Oops. Hey there. Hi, Alex. Hi, Julie.
Hi,
this is Mary. Thank you so much for an interesting talk, Julie. I'm interested a little bit as you kept kind of talking and alluding to the lack of standards or lack of recognition kind of thing, and then also clinicians' availability to do this. And I'm wondering about like an elective certification of sorts and leaning a little bit on some of our experiences in ISWP and wondering, are there any, or do you see a market for some kind of like add-on stackable certificate or specialty certification or something like that related to mHealth apps?
I absolutely do. I'm glad you brought that up because I had this highly overambitious R01 written right after I graduated. And one of the aims was the development of an education program complete with digital badges. As I said, it was a really overambitious grant, but I still have it. And I still have kind of a pipe dream that we'll be able to enact the different components of it. And one of the things that we said was we wanted the heart to be accessible, whether or not you were a clinician. We wanted it to be something that caregivers could use, right? But we also liked the idea of perhaps organization level buy-in. So it would be beneficial to various healthcare organizations to have clinicians who are certified, formally trained in completing the heart so that they were encouraged to use more mHealth in their practice and they could use it with confidence. And so if they completed the education program, they would have a digital badge that they could display on their LinkedIn, that the organization could display and count for the number of clinicians that they have. So I have certainly played around with the idea. We have not moved farther than that, only because we're still in the early stages of the project. But if that's something that ISWP can support, I certainly think it's a wonderful idea. Does that answer the question?
I would love to, yeah, absolutely. I'd love to talk more with you about it and even partner or collaborate if there'd be an opportunity. And then unrelated, but related to the chat in general, the discussion in general, I added an article in there. I wrote a commentary with some colleagues from the School of Computing and Information on accountable software. So I was nodding my head as you were talking about those things and really just learning about the topic, but wanted to share that for those who are interested in this idea and topic. So thank you so much.
Thank you. Thank you so much. And I'd be happy to provide different components of this presentation or the references. I'll put it here so you can see those video links. upon request, I'll go ahead and put my contact in the chat.